my name is Lisa Torres. I am a speech-language pathologist and clinical specialist with Passy-Muir. I will be presenting information on the physiological and cost-effective benefits of the Passy-Muir valves. This video will complement our clinical video, which presents information on assessment, placement, transitioning, and troubleshooting issues with the Passy-Muir valves. In order to understand the physiology of the Passy-Muir valve, we must first look at a patient without the Passy-Muir valve and with an inflated cuff on the trach tube. This patient is inhaling and exhaling only through the tube. Because the cuff is inflated, there is no airflow through the upper airway. With an inflated cuff, it can tether the larynx, and the larynx needs to elevate for an efficient swallow. Now, if you put your fingers on your throat and swallow, you can feel how the larynx elevates and how much it needs to elevate and move forward in order for the epiglottis to flap back and protect the airway. This allows protection of the airway and decreases aspiration for this type of patient. Another thing, because of the inflated cuff, is there's no airflow through the upper airway, and so there's a lack of sensation in the back of the throat, or the oropharynx. With this lack of sensation, the patients aren't able to feel their pooled secretions or any material that may go down into the throat. For example, if we were to drink a milkshake or to eat some pudding, and if it were to get caught in the back of our throat, we would feel it, and we would clear our throats, or we would cough it up and swallow it back. And these patients are unable to do that. In addition, the airflow past the vocal cords allows the vocal cords to go into a closed position. Because there are baroreceptors, or pressure receptors, beneath the level of the vocal cords that require airflow to allow them to move into a closed position. So a patient with an inflated cuff has vocal cords that remain in an open position. So they have an open system here at the vocal cords and an open system here at the trach tube. And because of that, there is no pressure beneath the level of the vocal cords. Their lungs are open to the same atmospheric pressure outside the trach tube. Because they don't have this pressure, which is called subglottic pressure, these patients are more at risk for aspiration and have more difficulty swallowing than those patients who have a closed tracheostomy tube or are using the Passy-Muir valve. The lack of airflow also does not allow the patient to have the sense of smell or the sense of taste. And the sense of smell and sense of taste is very important for these patients because the sense of smell and taste leads to a better appetite, and it also leads to improved nutrition. And nutrition is very important for these patients because they are respiratory compromised. Our goal is to get them the best nutrition as possible. In fact, many of these patients, because they lack that appetite and because they have such difficulty swallowing, actually will have some type of a tube, either a J tube or a G tube for feeding, because we are not able to feed these patients orally. This lack of pressure also does not allow the patient to have an effective and efficient cough. And without an effective and efficient cough, and because they can't sense anything that goes past the vocal cords, they are more at risk for aspiration due to that as well. Because the vocal cords are in an open position, and because they have no pressure beneath the level of vocal cords, these patients also do not have natural physiologic PEEP, peak end expiratory pressure. And PEEP is very important for our patients because what PEEP does is it allows the patients to have improved oxygenation. And what happens with PEEP is that there are small little balloons at the end of our lungs, and these little balloons, when they're open to atmospheric pressure, will deflate a little bit. They'll be closed. And because of that, there's less surface area or less area for the gas exchange to occur. So these patients with an open trach tube and an inflated cuff have reduced PEEP, and therefore they also have reduced oxygenation. Next, I will deflate the cuff in order to demonstrate an open position valve. All other valves other than the Passy-Muir valves are open position speaking valves. With an open position valve, the diaphragm is already in an open position. So when the patient inhales, the diaphragm is already open. In order to close the diaphragm of the valve, the patient has to exhale up the tube to push the diaphragm to the face of the valve. And when this happens, the diaphragm doesn't completely close. The diaphragm will vibrate or oscillate, and some of the air still comes out through the front of the valve. In addition, to close the diaphragm of the valve, the patient has to exhale through the tube. And when this happens, secretions also travel up the tube and occlude the valve. So some open position valves, such as this valve, have a mechanism like a flip-top cap so that the clinicians can suction the secretions out of the front of the valve. Now this type of valve does not create a closed system because some of the air is still traveling out through the valve. So this patient has the benefit only of communication. Next, I will demonstrate the physiological benefits of a closed position valve. First, you must completely deflate the cuff of the tracheostomy tube. Now, it is often thought that an inflated cuff of the tracheostomy tube helps to prevent aspiration. However, this is not true. The definition of aspiration is any material that has penetrated the level of the vocal folds. So even with an inflated cuff, the patient has already aspirated because the material has passed through the vocal cords and is just sitting on top of the cuff, waiting for someone to come along and to deflate the cuff, which then it will enter the lungs, or if the cuff is inflated, it may trickle past the cuff with time. So with the Passy-Muir valve, you must first deflate the cuff, and then you place the Passy-Muir valve. The Passy-Muir valve is the only closed position, no leak valve. So what this means is that the diaphragm of the valve starts in a closed position. So the patient inhales to open the diaphragm of the valve, and the air enters the tracheostomy tube and into the lungs. But at the end of inspiration, the diaphragm closes automatically, and there's no air leak back out through the valve. So what happens is the patient inhales through the valve, and the diaphragm opens, and then the diaphragm closes, which creates a column of air within the tracheostomy tube, which acts as a buffer from secretions traveling back up the tube and into the valve. Because the valve is closed here at the tracheostomy tube, all of the air is available to travel around the tube and up and through the vocal cords, allowing the patient to speak. That is the first benefit of the Passy-Muir valve. Another thing is, because we have the airflow restored through the upper airway, the patient has restored sense of smell and sense of taste. And as I have said before, the sense of smell and sense of taste is very important to improve the appetite and therefore improve the patient's nutritional intake. Of course, because now we have deflated the cuff, the patient has better laryngeal excursion. This patient is now able to elevate the larynx, and the epiglottis is able to flap back and protect the airway. So they have a protection here right above the level of the vocal cords. Now that we've restored the airflow and we have that pressure here beneath the level of vocal cords, instead of being in an open position, the vocal cords will go to a closed position. So we have closed vocal cords here, and we have the epiglottis flap back here. So we have our two natural barriers from aspiration in place once we have the Passy-Muir valve on and the cuff deflated. Because of the restored airflow, we also have the improved sensation in the oropharynx. So this patient is able to better sense their pooled secretions or any of the material that they may be attempting to swallow. Because we have a closed system here and the closed vocal cords, the fourth thing that we've done for the swallow is we've helped to restore subglottic pressure. And independent research studies show that subglottic pressure helps to facilitate a better swallow and decrease aspiration in patients who are utilizing the valve. This study used patients with modified barium swallow, and they would have the patient swallow with the valve off, and the patient would aspirate. And then they would place the Passy-Muir valve on, and the patient would not aspirate. The researchers in this study found that the swallow is not just mechanical, but also pneumatic as well. They found that with use of the Passy-Muir valve and being able to close the system, they were able to theorize that the swallow is also a pneumatic system. That with the swallow we have two chambers. We have the trachea and we have the esophagus. And when we have a closed system here in the trachea and we have positive pressure on this side, we have negative pressure in the esophagus. And so the swallow works like a pneumatic system, and when the epiglottis flaps back and the pressure changes, the food is more easily able to go down into the esophagus. Another thing, because we've restored this pressure, is that we have a more efficient and an effective cough. So now the patient has the pressure to cough and to either expectorate orally the material that they are having difficulty with, or to swallow it back and manage it as we do. You don't realize that we are constantly managing our secretions and we're swallowing back on a normal basis. So now we've allowed these patients to do so. We've also helped to restore this pressure beneath the level of the vocal cords. So we've helped to restore PEEP, positive end expiratory pressure. And as I said before, instead of having those little balloons, those alveoli that are deflated, now because we have the restored pressures, these alveoli are able to open up like inflated balloons. And with this inflation, we have more surface area. So the surface area now allows for improved gas exchange. So you'll see in patients who are utilizing the Passy-Muir valves, when you're using a saturation monitor, that their oxygen saturation levels will increase. Because the patient is now exhaling past their own natural anatomy and past the trach tube, they're using their expiratory muscles. Instead of just passively exhaling out through the trach tube, they have to exhale. And because they're doing this and using their expiratory muscles, it's helping with the weaning and decannulation process. These patients are utilizing the Passy-Muir valve as a transitioning tool for decannulation. And studies indicate that when using the Passy-Muir valve, the patient is able to be decannulated anywhere from 3 to 5 days sooner using the Passy-Muir valve than with the standard capping method. Since this patient is utilizing their expiratory muscles, and since they're exhaling past their own natural anatomy, this patient, when utilizing the Passy-Muir valve, is able to be weaned from the ventilator much sooner. This patient, if they're in an ICU, can be transferred out of the ICU and onto a medical floor much sooner. Or if they're in the hospital, they can be transferred to a home type of setting much sooner when using the Passy-Muir valve. Now, because we have restored the closed system, what we've done is we've restored this patient's natural physiological state. What we've done is we've, one, deflated the cuff, which allows the larynx to elevate and the epiglottis to flap back. Two, we've helped to restore the airflow, so they have improved sensation in the upper airway. Three, we have improved the airflow past the vocal cords, which allows the vocal cords to go into a closed position, which helps to protect the airway. And four, what we've done is we've helped to restore that subglottic pressure. And because we have significantly improved the patient's swallow and decreased aspiration, and because we've helped this patient to manage the secretions much better, they have a reduced need for suctioning. So they have less time that the clinicians will need to spend with this patient, and they have less requirements for suctioning. In conclusion, with use of the Passy-Muir valve, we have restored this patient to a more normal physiological state. We have reduced the complications due to the tracheostomy tube itself, and we have improved the overall health status of this patient. To summarize, the cost benefits of the Passy-Muir valve include improved swallow, which decreases the patient's suctioning needs and associated costs, decreased aspiration, which may allow the patient to avoid a course of antibiotics for treatment of aspiration pneumonia, decreasing the possibility for the insertion of a J-tube or a PEG, improved weaning times, which results in transferring the patient out of the ICU or hospital sooner, and thereby decreasing the overall length of stay. With a Passy-Muir valve for less than $1 a day, you will restore the patient's natural physiology, reduce the complications and related costs, and improve the patient's well-being and quality of care. For further education on the application of the Passy-Muir valves, please visit our website at www.passy-muir.com. There you will find our free continuing education courses, which include assessment and placement issues, transitioning issues, ventilator issues, dysphagia issues, and pediatric issues. You may also download the clinical instruction booklet, patient handbook, and request our free clinical in-service video.
The Passy-Muir valves are prescription devices that can be purchased by physicians, patient care facilities, and home care equipment companies. We encourage you to contact us if you have additional questions, would like to receive more information, or to share your comments and suggestions concerning this video or our products.
My name is Curtis Powell. I'm Manager of Respiratory Care here at Vencor Hospital, Ontario. It has been our distinct pleasure to be a part of this training video for the Passy-Muir Company and for the Passy-Muir valves. I've been the manager since the inception of Vencor, which is approximately 6 years ago. At the very beginning, we trialed many speaking valves trying to help our patients, and I've got to tell you, the Passy-Muir was the best speaking valve that we were able to find. Other valves tended to fall apart or were difficult for the patients to utilize. The Passy-Muir had distinct advantages that the other valves did not have. Those included ease of use, not only for the patient, but also for the caregiver, for those that were applying the valve. And the valve has just been a phenomenal success for us. Perhaps the advantage that I have as a manager is that the staff is able to utilize the valve. It's easy to use. They're able to learn it in a very quick manner. And in today's healthcare environment, I don't have a lot of time for orientation, so they need to learn things quickly and learn it well. The valve, because of the ease of use, gives me that opportunity. In weaning, we have found that the valve has actually enhanced the weaning process, that we feel like our patients have weaned better. Part of that process has been because the patients have been able to develop some of their own auto-peep. On top of the auto-peep, we have enhanced secretion clearance. Patients just have a better attitude when they're wearing the valve. On top of the auto-peep and that, we've also found a marked decrease in the amount of aspirations. Approximately 70% is what we saw when we started utilizing the Passy-Muir valve. As it stands now, every patient that is on a ventilator, or even a patient that is not on a ventilator, if they can tolerate the valve, when they're eating, the valve is in place, because we found that the risk of aspiration is so much reduced, and it greatly enhances that. As far as our patients, we're excited because every patient that comes in, whether they have a tracheostomy tube with a simple aerosol or on a ventilator, we attempt at first a chance that we possibly can to place them on the valve. Respiratory care in conjunction with speech therapy, we have been so grateful because as we place the patients on the valve, not only do we give the patient a voice back, but we give the patient something that they haven't had for a long time, and that's hope. That's a voice in their own care and in what they can say about their own care that they're being given. We highly encourage the use of the Passy-Muir valve.
On behalf of Passy-Muir, we welcome you to the videotape presentation of our in-service on the application of the Passy-Muir tracheostomy and ventilator speaking valves with adults. We have prepared this tape to enable facilities to provide their staff with the information necessary to utilize the Passy-Muir valves appropriately and effectively with their adult tracheostomized and ventilator-dependent patients. This videotape should be used in conjunction with the Passy-Muir in-service outline provided with this tape, as well as the Passy-Muir instruction booklets that are packaged with every valve. We hope that you find the following in-service valuable and easy to apply to your healthcare setting. For information regarding use of the Passy-Muir valve with neonatal and pediatric tracheostomized and ventilator-dependent patients, please refer to the pediatric section of this videotape. The Passy-Muir tracheostomy and ventilator speaking valves are the innovative invention of David Muir, who, as a result of muscular dystrophy, was quadriplegic. In 1985, he required a tracheostomy and became ventilator dependent, which rendered him unable to communicate. He tried to utilize the communication products available at the time for tracheostomized individuals. However, none of them worked to his satisfaction. With his own idea of how a one-way speaking valve should work and his father's assistance, David developed the Passy-Muir valves, which enabled him to speak normally both on and off the ventilator. For nearly 6 years, David had the satisfaction of seeing both children and adults benefit from his invention. David passed away in August 1990 at the age of 28. David's legacy, the Passy-Muir valve, has returned independence and dignity to thousands of tracheostomized and ventilator-dependent individuals all over the world. The Passy-Muir tracheostomy and ventilator speaking valves are small, lightweight, and designed to fit the universal 15-millimeter hub of adult, pediatric, and neonatal tracheostomy tubes. The Passy-Muir valves have the unique, patented closed-position no-leak design, which enables these valves to be used in multiple clinical applications, including communication, swallowing, secretion management, ventilator weaning, and decannulation. The Passy-Muir valves are safe to use with neonatal, pediatric, and adult patients, and may be utilized across the continuum of care, from acute care to home care. These valves are designed for use both on and off the ventilator. There are currently 5 models of Passy-Muir valves available. The PMV-005 white tracheostomy and ventilator speaking valve is the original low-profile Passy-Muir valve with a 15 mm inner diameter and a 23 mm outer diameter. While it is more often used by non-ventilator dependent tracheostomized individuals, it can be placed in line with a ventilator using non-disposable flexible rubber tubing. The PMV-007 Aqua tracheostomy and ventilator speaking valve also has a 15 mm inner diameter, but this valve is tapered and has a 22 mm outer diameter to allow it to fit in line with standard plastic disposable ventilator tubing and adapters. The bright aqua color of this valve makes it easy to see on the tracheostomy tube, as well as in line. This valve, like the PMV-005, can be used both on and off the ventilator. The PMV-2000 Clear and the PMV-2001 Purple valves are lower profile, lower resistance tracheostomy and ventilator speaking valves. These valves represent a new generation of speaking valve that are smaller, lighter weight, and open upon inspiration even easier than the PMV-005 and PMV-007. The PMV-2000 valve is colorless to make it less visible on the tracheostomy tube, and it's often the preferred choice for the more ambulatory patient. In contrast, the PMV-2001 valve is a highly visible, bright purple color, designed to facilitate staff awareness of its use and whereabouts. Both of these valves are designed to be used with the PMV Secure-It, a device that allows the valve to remain connected to the tracheostomy tube tie to prevent valve loss. These valves have a 15 mm inner diameter and a 23 mm outer diameter and can be used off the ventilator as well as in line with flexible, rubber, non-disposable ventilator tubing. Both of these valves can be utilized with the PMV oxygen adapter. The PMV 2020 Clear tracheostomy speaking valve and PMA 2020S adapter are sold as a set and are designed for use with Pillingweck metal Jackson improved tracheostomy tubes, sizes 4 to 6 or equivalent. This is the only Passy-Muir valve that is not indicated for use in line with a ventilator. The Passy-Muir valve oxygen adapter allows for easy inhalation of low-flow supplemental oxygen and humidity through the PMV 2000 Clear and PMV 2001 Purple speaking valves. This adapter is small, lightweight, clear in color, and easily snaps onto the PMV 2000 and PMV 2001 valves. The PMV oxygen adapter is designed to enable oxygen delivery of up to 6 liters per minute in front of the intake side of the valve. This avoids complications associated with devices that provide continuous flow behind the valve, which may include air trapping, drying of secretions, and possible cilia damage. The PMA 2000 O2 adapter is not designed for use with the PMV 2020 speaking valve for metal trach tubes. Each Passy-Muir valve is packaged in a convenient and durable patient care kit designed to facilitate proper use and maintenance of the valve and continuity of patient care. The patient care kit is a Ziploc pouch which contains 1 Passy-Muir valve, 1 PMV storage container, an instruction booklet for healthcare professionals, and warning labels for use at the patient's bedside and in the chart. The patient handbook included is an excellent teaching tool useful for meeting JCAHO patient education requirements. Appropriate accessories, if any, will be packaged with the valves, such as the PMV Secure-It with the PMV 2000 and PMV 2001 valves, and the PMA 2020S adapter with the PMV 2020 valve. It is important to understand the significant design difference between the Passy-Muir valves, which are the only closed position valves, and all other speaking valves, which are open position valves. The Passy-Muir valve design promotes the establishment of a more normal closed respiratory system that in turn provides many clinical benefits not available with open position valves. The clinical benefits available through use of the Passy-Muir valve that will be discussed in this video can contribute significantly to cost-effective treatment for tracheostomized and ventilator-dependent patients. Use of the valve can expedite staff and patient communication, facilitate improved infection control, reduce suctioning needs, improve swallowing, increase oxygenation, and reduce ventilator weaning and decannulation time. As a result, the costs involved in these areas of patient care can be reduced. The Passy-Muir tracheostomy and ventilator speaking valves incorporate a unique patented design feature that translates into significant benefits which are not available with other tracheostomy valves. To understand the principle behind the Passy-Muir patented feature, it is important to first understand how other speaking valves operate. Most speaking valves use a membrane or diaphragm to perform the valve opening and closing functions. The membrane flexes during inhalation, which allows air to pass around it and through the tracheostomy tube. When the inhalation cycle reaches its peak, the membrane temporarily relaxes and returns to its normal position. At this point, the valve is not actually closed. Reversed airflow, which is produced by exhaling, is necessary to force the membrane against the valve body to produce a seal. Some valves never attain a complete seal and remain open even during the exhalation phase. Before the membrane actually closes, there is a short time lapse where some exhaled air can escape. In addition, some common breathing patterns create an airflow phenomenon that can cause the membrane to vibrate or oscillate, which prevents it from completely sealing, resulting in noise as air leaks out. The Passy-Muir valve has a patented feature that virtually eliminates the possibility of these kinds of problems. This feature creates a closed-position no-leak condition. The membrane's outer perimeter is forced to normally be in a state of compression against a lip inside the valve body. In a relaxed state, the valve is completely sealed, not requiring reversed airflow to close it. When inhalation begins, the membrane easily bends out of the way to allow air passage with minimal resistance. When the inhalation cycle reaches its peak with the Passy-Muir valve, air stops flowing, and the membrane instantly returns to its normal, fully sealed position. This is the closed position no-leak feature. As exhalation begins, the valve is already closed, and air immediately follows the path of least resistance up through the trachea and past the vocal cords, exiting through the nasal cavity and mouth. Because the valve closes before the end of exhalation, a column of air remains in the tracheostomy tube at all times, creating resistance to secretions coming up the tube and into the valve. The following demonstration will further illustrate the difference in the performance between an open position valve design and the closed position no-leak design for the Passy-Muir. Using a lung simulator, an open position valve exhibits noise and air leakage during the expiratory phase of breathing. In contrast, the Passy-Muir speaking valves allow no leakage of air during the expiratory phase due to the patented closed position no-leak design. The Passy-Muir valve remains positively closed without the air leak. However, when an open position valve is tested, a loud honking can be observed. Historically, extraneous noise has been a problem with open position valves. From a soft click to a loud honking, the noise of open position valves has created embarrassment and discomfort to patients. As you can see, the Passy-Muir valve is noiseless. The closed position no-leak design of the Passy-Muir valve allows significant secondary benefits that lead to improved patient outcomes and quality of life. In 1997, the Healthcare Financing Administration reported that the average length of stay for a tracheostomy patient in the hospital was 26.55 days, and that the cost for both tracheostomized patients and ventilator-assisted patients during their hospital stay ranged from $3,165 to $3,886 per day, suggesting significant cost savings benefits with use of the valve due to a decrease in technology requirements. The Passy-Muir valves are designed to eliminate the need for finger occlusion and to facilitate easier coordination of respiration with speech production. When using the valve, all exhaled air is diverted up past the vocal cords and through the oronasopharynx, allowing both tracheostomized and ventilator-dependent patients the opportunity to achieve improved vocal intensity and speech duration, longer sentences, and a more normal speech pattern. Thus, when using the valve, ventilator-dependent patients are not limited to speaking 1 or 2 syllables with the ventilator cycle, as they are when they use leak speech. In turn, utilization of the Passy-Muir valve to facilitate voice and speech can expedite more cost-effective patient care by decreasing clinical therapy hours provided to the patient, who can now easily vocalize his or her needs to physicians, nurses, and clinicians. The patient's ability to verbally communicate can also facilitate each clinician's efforts to assess the patient and more quickly identify appropriate therapy strategies. Improved communication skills may allow a patient to be treated in group therapy or co-treated with another service to decrease overall treatment hours and related costs. Many other clinical benefits are made available by the closed-position no-leak design of the Passy-Muir valves, including improved swallowing. Tracheostomized patients often have difficulty swallowing and are at risk for aspiration. The presence of a tracheostomy tube abolishes the pressures normally generated during swallowing because air escapes through the tracheostomy tube. The tracheostomy tube, especially one with an inflated cuff, also tends to anchor the larynx, interfering with laryngeal elevation and airway protection. Reduced sensation in the larynx and pharynx may also occur due to a lack of airflow through the upper airway. The Passy-Muir valves can improve swallowing and may reduce aspiration due to the fact that the valves restore a closed respiratory system and airflow through the upper airway, which in turn promotes restoration of subglottic air pressure and laryngeal and pharyngeal sensation. In addition, due to the need for tracheal cuff deflation when the valve is utilized, the anchoring effect that an inflated cuff can have on laryngeal movement may be reduced. Aspiration pneumonia is a serious yet common complication that occurs in tracheostomized and ventilator-dependent patients. There is a mortality rate of 30 to 50% for the diagnosis of aspiration pneumonia, according to a study by Beers and Burkow in 1999. The incidence of aspiration in tracheostomized patients is reported to range from 15 to 69%. In 1995, Dr. Amal Jubra wrote that approximately 30 to 40% of patients with well-documented aspiration pneumonia will develop adult respiratory distress syndrome, or ARDS, which is associated with a high mortality rate. The Passy-Muir valve facilitates improved swallowing and may reduce aspiration. Therefore, it can be a very cost-effective tool to utilize to ultimately expedite swallowing treatment, avoid the costs of treating aspiration pneumonia, increase oral intake, and improve nutritional status. In addition, use of the valve may help to avoid the thousands of dollars it costs for feeding tube placement and maintenance. In fact, Dr. Dettelbach and his research colleagues reported in 1995 that the Passy-Muir valve offers a valuable non-surgical means to help manage mild to moderate aspiration in patients with a tracheostomy. A therapeutic trial of valve use should be considered in selected patients with tracheostomy before more definitive procedures are employed to reduce or eliminate aspiration. The Passy-Muir valves facilitate secretion management as the patient is restored to a closed respiratory system. Restoration of a closed system enables stronger cough production. Patients can expectorate or swallow their secretions, requiring less suctioning. The restoration of airflow through the upper airway promotes evaporation of secretions pooled in the oral cavity and pharynx. Clinical time and material costs are significantly reduced. Serious and costly respiratory complications, such as pneumonia and/or atelectasis, may be avoided. The closed position no-leak design of the Passy-Muir valves also restores the positive airway pressure that is present in a normal closed respiratory system. This promotes the restoration of physiologic positive end expiratory pressure known as PEEP, facilitates improvement in oxygenation, and can improve the ability to perform a Valsalva maneuver. Physiologic PEEP opens the alveoli, allowing air to move beneath secretions and gently push them towards the larger airways, thereby further promoting secretion management and reducing the risk for pneumonia from retained secretions. Reestablishment of physiologic PEEP can provide a simple and cost-effective means